And we're back. We have Noah Mandel, a fellow podcaster. Noah, thanks for coming on, man. Can you just tell us your story? I initially found out about you through somehow I found your podcast, and I'm insanely jealous of how comfortable you are as a interviewer. And I really appreciate what you're doing with Forward Physio. But can you just give us some information about yourself, some of your background?
Yeah, thanks for having me on, Chris. I'm hopefully as comfortable as an interviewee as well. Um, so I am a Canadian physiotherapist. Actually, before I introduce myself, I just want to say thank you. I'm a huge fan of E3. I've been listening to your own podcast for quite a while now, and I love what you guys put out. Anytime I see a patient who says that they found some content online, I'm usually afraid and nervous as to what they saw. But anytime they say it's E3 on YouTube or something, it's always very relieving. So I appreciate everything you guys do. Um, I'm a Canadian physiotherapist. I work in Toronto, and I was born and raised here. I've been working for only about a year now. And as I sort of finished up my time as a student, I began working for Physio Network and doing some of the social media stuff for them. And I'm just very, very passionate about like critical thinking and sort of updating our worldview and trying to look at things under a different lens from the ones that we're commonly taught. And just trying to, as my podcast is called Forward Physio, is to push the profession forward. So that's sort of what I'm about as, I guess, an individual professionally.
Yeah, we're similar timelines out. I'm about a year and a half out. So I think the conversation today will have, I think, very similar experiences as new grads and recently out of the education system. The topic for today is largely going to be about posture in a variety of contexts, but you made a pretty popular post I think in November on this topic, and it incentivized me to reach out and dive into it further with you over the podcast. So let's start with in school, when you were in your physio program, how were you initially taught to look at someone's gait? What were they saying about posture? What was your just initial exposure from a school setting to posture?
Mm-hmm. Yeah, for anybody that looks at that video, it was like a 40-second clip. So I'm happy that we have the time here to dive into a little bit more of the nuance because, that never 40 seconds is obviously not enough time to dive deep into a topic. But essentially what I was saying in that video was oftentimes in schools, we're taught that if we see something in someone's gait, we're meant to correct it. And I want to be fair to my schooling for sure. I think there was a ton of really, really good stuff that I learned in physio school. And there was a huge emphasis on the biopsychosocial model. And there were a lot of talks about how, posture may or may not be a problem and the way someone moves may not be a problem. But at the same time, we would sort of learn that stuff. And then in lab, we would spend a lot of time breaking down people's posture and their movement patterns and looking how to correct it. I remember I was actually looking back at some of my notes in preparation for this podcast, and early on, we were taught about the plumb line. We were taught about different types of posture, like the kyphotic, the sway back, one of them, which is called ideal, which I definitely disagree with. So it felt like in school, we were really taught to emphasize critical thinking and this biopsychosocial model, but it felt like it was at this weird transition phase where although we appreciate that not everything is just based off of structuralism and the biomedical model when it comes to pain, it felt like just in lab and in practice, we didn't know how to quite get away from that yet. And my concern is that it may have left a lot of students feeling a little bit confused about, so like, why are we looking at the posture then? What do we make of this? So I think that is a pretty good summary of what we learned in my schooling. But I get people reaching out to me all the time telling me that they learned stuff that is a little bit more entrenched in the biomedical model in school. So the video that I created when I said in school, it wasn't just about mine. It was sort of about schools in general that are still sort of ingrained in this really biomedical model.
Yeah, and you gave a good caveat as to this isn't to shit talk the entire schooling that you received or all programs, but in general, this is still the norm. But there were even, I just re-looked at that post, and there's, I think it was Rich Willie who commented, like with Montana Running Lab, he's like, our program is in a much better spot than this, or however he framed it. So there are people, clinicians and researchers doing phenomenal things in academia and with students, but I would still say it's very much more of the norm to have these outdated beliefs still being taught. And personally, my education was very similar to how you described it. When you were in school, were you already skeptical of these things, or what was your reaction when they were being taught?
Yeah, we learned MSK in two different units. And firstly, going into physio school, I was already someone who was a little bit more skeptical in nature because when I was doing my undergraduate degree, which was not in nutrition, I thought I was a nutrition expert because I listened to a lot of pseudoscience stuff online and I thought I knew everything. And I wasn't thinking critically. I just believed stuff that sounded sciencey. And then over the years, I started coming across some people in nutrition that are a bit more evidence based and some researchers. And it was a really painful process of unlearning all of the nonsense that I believed. So going into physio school, I didn't want to repeat that same mistake. So I always try and take things with a little bit of a grain of salt and understand that um, things aren't black and white. And again, to give a lot of credit to my schooling, the most common thing, and I know other physios can relate to this, the most common saying was "it depends." So it wasn't like it was always this black and white thing in school. And they really emphasized being comfortable in that gray area, which some people might not love because they want answers and concrete rules about, how to navigate their decision making. But that's where I love to be. So for me, that was relieving. So yeah, I was skeptical. And then by the time we got to the second unit of MSK related stuff in school, I had become really like I started learning a lot about like from people like E3, like from Greg Lehman, Adam Meekins, Ben Cormack, Jared Powell. So at that point, I was, sort of leaning on a bunch of podcasts and reading research to counteract sort of what I was learning in school sometimes. So by that time, I was certainly very skeptical, but maybe not right off the bat.
Did you have any conflicts or butting of heads with professors or fellow students?
Um, I mean, anyone in the program who knew me well certainly knows that on the walks home after labs, I would definitely have some opinions, um, maybe too many strong ones. I never butted heads with the profs. I raised concerns sometimes, and they were always so reasonable. And they would say things. I'm like, does this posture matter, for example? And they say it may or it may not. And I think that's great. But again, I think the thing that we were mainly missing was just, I guess, not necessarily a definitive standpoint, but at least a framework of how to navigate when movement analysis and posture analysis is important and when isn't it. Because I feel like all we sort of got for sure was it may matter sometimes, it may not. But I think my big question, and maybe some other students in the program, was okay, well, when and why would it matter?
Let's dive into it. So maybe we start with what you initially mentioned in your 40-second reel or recording of what is the issue with making some of these outright black and white conclusions about the way someone walks or the way someone stands or sits. Let's go into why that's a concern, and then we'll lead after that into these caveats as potentially when it does matter to look at posture.
Okay. There's I think a lot of ways that we could go about sort of dissecting why there's issues with that. And I think if someone's taking a look at your posture or a patient's posture or the way that they're walking, and they're making diagnostic claims based off that alone, I do think that's a massive problem. So let's say classically, if we think about something like upper cross syndrome or lower cross syndrome, where we see someone who has this maybe hunched over posture. Let's talk about upper cross syndrome. So like rounded shoulders, we can't just simply conclude that they have, a tight chest and a weak back just based off of that position alone. One reason being is because we live our life moving, and static posture doesn't tell us too much. And it's not just tight or strong or weak or loose muscles that influence posture. So if I ask you to think of someone's posture when they're sad, I'm sure an image comes to your mind, right? Maybe they have that same sort of upper cross looking posture. And if I ask you to think of someone's posture who's really happy, maybe they're more confident, maybe they're more upright. So even emotions can play a role. If someone is in pain, they might have a different posture. They might have adopted a more comfortable position. So I think an interesting example recently is I'm dealing with a cervical radiculopathy, and I no longer have pain, which is awesome. But when I did, the position for me that wasn't comfortable was slouching. So my concern there is if I was someone who maybe wasn't health literate and I went to see a physiotherapist and it hurt when I slouch, that they would conclude that, it's bad to slouch and that's why I have pain. When in reality, I got pain from jujitsu. Someone was trying to hurt my neck and they did a really good job of it. So, that's an example there where sometimes we have this post hoc fallacy. When we look at someone, how someone moves or how someone sits or whatever, and we look at their positioning and it's a painful positioning, we can't conclude that that's their problem. It may have been emergent after the pain. So I think that's one sort of avenue that we could take when we're dissecting that issue of, why can we not make those diagnostic claims? Another one is because we're not very great at assessing posture and movement visually. There was a study that came out last year when we were basically it had certain. I think there was a surgeon with 10 years of experience, one with 5. There was a resident and a researcher, and they were tasked to compare, basically to look at knee alignment in a standing posture. And they compared that with x-rays of the same persons. And they found that 50% of the time they diagnosed normal elite knee alignment to be out of alignment. And these are people with experience, and the experience levels did not differ or did not cause any differences in the accuracy of how they judged their alignment. And that's just in standing. Right. And if we look at things like palpation or starting to look at movement with our eyes, we could also find instances in the literature where like these aren't necessarily as accurate as well. So that's another issue. We're just not good at it. And another issue with looking at that sort of claim that, if you're moving or sitting in this sort of way, that's an issue, is that a lot of the time, these things, firstly, aren't predictive of pain being caused by these postures. And we often see that these things don't need to change in order for people to recover from pain. So a good example of that would be something like scapular dyskinesis, where a systematic review, I think it came out I think it was last year, basically saw that about 50% of the population who was asymptomatic had scapular dyskinesis. About 80% of the population that is asymptomatic with low back pain has anterior pelvic tilt. A lot of the time, these things are normal. And if we look at something like scapular dyskinesis or like knee abduction or valgus, oftentimes our approaches to try and change these things, like with exercises, for example, they work pretty well, but from a pain standpoint, but they don't always work from a movement standpoint. So we could see people recover before and after without their kinematics really changing.
Have you ever read The Normal and the Pathological? Have you ever heard of that book?
No.
I don't know how to pronounce the guy's name. Georges Canguilhem. I read it maybe in grad school right before, and it was a phenomenal read on how variable people's body structure is, from internal organs to bony structure to their posture to all these other things. And it just gives a great perspective on how messy and blurred and gray the lines are between what is quote unquote normal and ideal and not. And the end conclusion is it's really hard to define what is normal or acceptable, because there's so many people that live their lives in so many varied positions and states, and they're completely healthy, happy, fine. And what was interesting, I'd be curious to hear your thoughts. I remember writing on the old school, like, clinical athlete forum, if you ever heard about that. But I remember writing kind of a post when I was in grad school about this contrast of my neuro class and how the posture a lot of times was viewed as like this adaptive, efficient, like task-based thing. And you're seeing someone that has a stroke or has an amputation or has all these neurological deficits, where it's not this deficit or abnormal view. It's like, let's move forward from here and accomplish what they need to achieve. And it's so much more oriented away from posture and pain. It's more, these are their limitations and constraints. How do we move around that to achieve the goal? And then going to my orthopedic class the hour later, and it's like pathologizing someone that has forward head position and they're gonna die. It's just that was the wild contrast. Like, even in the same program, the views of the neurological rehab and the orthopedic, at least in my program, was polar opposites. I don't know if you had that experience, but also to me, it was like the people that inherently are the most limited potentially with their mobility are not, they're treated way more as the task is the goal and achieving things, as opposed to just like feeling a deficit, which felt strongly the case in the orthopedic curriculum.
Yeah. In our neuro unit, a lot of the time, maybe changing posture became relevant if it involved completing the task a little bit better. It wasn't to fix posture from a diagnostic standpoint. And that's one example. I know we'll get into it a little bit, but like, where I think it's okay to change posture. If there's a task at hand where one position better suits that task, go for it. But that doesn't mean that the other posture was something that needs to be over medicalized and deemed a pathology. Or we don't need to act like it's doomsday when someone's in that posture. Maybe it's just not appropriate for that context. So yeah, and I agree with what you were saying before. Like, variability is the norm, not just between people, but within people as well. So again, different emotions, we might have different postures. Different tasks, we might have different postures. So, and even on this asymmetry thing, like, we're born asymmetrical. We're all born with a dominant hand, right? So we're born off the bat being able to use one of our arms better than the other. Like, you could throw well with one and the other looks like a floppy noodle. That's how we're born. So asymmetry and variability is the norm in a lot of cases.
How do you have these conversations as a clinician with patients when they're coming in, maybe assuming that their condition or their injury or their pain is because of their posture or their alignment? How do you reorient them to maybe thinking otherwise? Or at what point do you kind of interject your thoughts versus just kind of letting them continue those beliefs? Because sometimes it's not helpful to change people's minds, or it's not warranted.
Yeah. First thing is, I usually tell them that I'm right and they're wrong. And that usually goes really, really well. It depends on the circumstance. It really does. And as you said, like, sometimes I will more so interject and try and challenge beliefs. I think the first step is sort of just getting a feel for that person. Some people on day one just have a lot of trust in healthcare providers and are very open-minded at the same time. And it's very easy to just share your opinion with these sorts of people. Like recently I had someone come in who was saying that they saw a different healthcare professional who told them that their foot was out of alignment. And I could tell this person didn't have a great relationship with that other healthcare provider. They're saying they're doing these manipulations on my foot and it hurts. And I don't know if I'm getting better. And I could kind of get the sense that they were looking for a different answer. So that's a time when I'll ask them, is it okay if I share my thoughts? Other times, let's say someone comes in with a problem that they blame on their posture. Sometimes that they blame on their own posture, and they feel very convinced about that. Instead of immediately trying to say, well, actually, here's what the research says, oftentimes those conversations don't go very well, especially if you don't have trust that has been built and a rapport that's been built with that person. So I think it's good to explore their thoughts a little bit more sometimes. Ask them questions. Like, were you always sitting like this? Uh-huh. And did you have pain like 2 years ago as well? Not really. And sometimes maybe like you can talk into this sort of like expectancy violation type thing. Well, or this sort of learnt, how do I say this? You can have the conversation go in a direction that leads their beliefs to be challenged a little bit less abruptly and aggressively than just saying like, here's what the research says. And then there's other times when someone doesn't seem to be very concerned about their pain. They say in the past, I just like know that I just strengthened my core and I worked on my posture and it helped a lot. And you kind of get the sense that they're not really concerned. And that if you've read some of the research, that many forms of exercise for back pain work pretty well, and they're not necessarily superior to one another, and core strengthening is a viable strategy. You could say, I'm happy to go down that route. Just so I think there's other options, and I'm happy to explore those ones with you and sort of explain my rationale. But I think the plan that you propose could work. So not everything needs to be challenged day one, and it's obviously very, very circumstantial depending on the person. But I do want to make that reiterate that point where I think it's better to have a conversation about these things instead of talking at the person about why they're wrong.
Let's go into the times when posture and looking at posture and gait and movement matters.
Mm-hmm.
We can start wherever you'd like, but is there an initial area within this topic that you think is a good starting point?
Yeah, I think symptom modification is a pretty good starting point. So if we go back to that example of myself, when I had the pain from the cervical radiculopathy, in that case, I'm not just going to tell somebody, let's say someone else had that exact same presentation and they said it really hurts when I slouch, and it feels good when I have quote unquote good posture. I wouldn't tell that person, hey, posture doesn't matter, sit however you want, knowing that it's making their symptoms worse. So it's very different to say that posture doesn't always cause pain compared to saying that sometimes posture can exacerbate a problem. And I like to use this sort of like lemon or salt in the wound analogy. Lemon or salt are not inherently bad things, but in a certain context, they can make pain arise, like if you put it in a wound, right? So sometimes posture is like that as well. If you have an issue, sometimes posture or your positioning or a certain movement pattern can be like salt in the wound. So if you think as a clinician it's appropriate to change to down regulate somebody's symptoms, then looking at their movement and their posture and the positions that exacerbate their pain and wanting to change that temporarily is a perfectly okay strategy. I just think a lot of the time clinicians do that, and then the person feels better and they say, okay, great, I found a fix and I cured that person, when in reality you just stop putting lemon in their wound, and sometimes over time that wound healed. So what I like to do is temporarily say, hey, let's stop rubbing lemon all over that wound. And then once you feel ready, we can start to move again, and we can start to explore these movements, and we can readapt to all the positions before that were causing you pain. And that's not just about, I guess, posture in the classic terms that we think about it when, it's either like you have good posture or you're slouched when you're sitting. But we could also look at movement in that same lens. If someone has something like patellofemoral pain or quadricep tendinopathy, a lot of the time more knee dominant movements in the gym or in life might bother them, right? Like going downstairs or doing barbell squats or like an ass to grass heel elevated squat. So we could say, hey, for now, we can try to get the hips a little bit more involved. We could do things more like RDLs or deadlifts. And then over time, as you improve, we can build back up these more knee dominant strategies. And it's not to say that before the knee dominant strategies were bad. Greg Lehman said something amazing along these lines. Like so many times when it comes to posture, and it causes pain in the moment, like with my cervical radiculopathy, we say that, oh, that posture is bad. But Greg said it's akin to saying that stairs are bad when someone's knee pain manifests on stairs. Like that's just the context where their pain is manifesting. That doesn't mean that it's always a bad thing. So I think that that's one area where it's okay to want to change posture and movement when it comes to modifying symptoms. Another one is, let's say we're talking about gait analysis. If we're getting someone who is like a post-op Achilles rupture patient or a post-op ACL patient, and they're limping a lot, it's probably a good idea to take a look at their gait and help them restore it. Because they're not loading these areas as they typically would, and ideally we can get them back to walking normally, and sort of as simple as that. And it's not to say that in the moment, if someone's limping, that we need to correct that, because sometimes the limp is protective. But if you deem that they're at a point where they maybe don't need to protect their tissues as much and they could start loading them a little bit more appropriately, then why not take a look at their gait and sort of analyze what's going on there and try and get them to move a little bit better. That's perfectly okay. What I don't do though in clinic is have someone with a long-standing pain and look at how they move and then blame the way that they move to be the reason for their pain. Because again, that could be a post hoc fallacy. Even if you find that moving in a different way feels a little bit better for them, that doesn't mean that the way they're moving before is inherently bad. And it's likely that they can readapt to those positions if they sort of, in some cases, calm it down, and then you can build it back up. Another one where it matters is if you're training and you have more specific targets with your training. We sort of spoke about knee versus hip dominant movements. And if you're a bodybuilder who wants to train quads, then there are better exercises to get you to do that, right? There's exercises that load your quads better than your hips. So in a bodybuilding context, that's pretty obvious, but how does that affect things at a rehab level? Well, a lot of the time, if we look at the mediating variables for pain, they're not obvious. And in 2024, we don't always know why people get better, but it doesn't seem to be as simple as, oh, you just need to get this exact tissue stronger when it comes to, like shoulder pain, for example. If we give someone a rotator cuff program and it's meant to strengthen them, we don't always need to see strength improve in order for them to get better. Or we don't need to see scapular kinematics change in order for them to get better. So sometimes in a rehab context, all I care about for form, and this is, I want to say in some contexts, there's other times where I'm way more specific about this, but as long as someone is doing the movement that's pretty similar to what I think they should be doing, I'm not too nitpicky with how they're moving. So there's someone, for example, who had back pain for 10 years. And she was told to never lift with her back and never lift more than 10 pounds. And she didn't for 10 years. So when I'm working with her to try and get her to believe in her back again and lift, I don't think that pairs very well with being incredibly precise about how she's moving and say, no, 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 don't move like that. Don't pick it up like that. That's going to hurt your back. Where I'm just in that context, setting up the environment and the tasks so that she could easily achieve it. And then over time, helping her achieve that task in a harder and harder way. And I'm not too nitpicky about how she's lifting as long as I think she's safe. But if I thought, like you really need to strengthen this exact tissue that in that certain context, like maybe if it was post-op ACL, and I think, hey, you really need to strengthen your quads here, then maybe I'll be a little bit more specific with how they're actually doing their movement.
Yeah, thanks for giving all those different examples. I agree with all of them. And it shows that we're not demonizing posture. We're just explaining the limitations of utilizing it as a diagnostic assessment for pain and demonizing one position over another, or using these really frustrating narratives that a lot of patients and the lay public receive and are just commonly heard on a daily basis. So from here, where do you want to go with this conversation? Do you have any examples or recommendations for students or clinicians on how to navigate this uh, difficulty of what they're being taught in school or what their patients are telling them, and trying to not just live in this like black and white and understand the gray? Do you have any ideas of how we can do better
With living in the gray?
Mm-hmm.
Yeah, well, first off, science is only around because we realize that we're ignorant. Before science, we thought we knew everything. We had all the answers. The very essence of science is understanding that we don't know everything and that we're trying to learn more. So it's not about having all of the answers. So a lot of the time, I think in our culture, we think about science as, like in the news, we'll say scientists say, and then that's meant to be taken as gospel. But that's not what the essence of science is. We're starting from a place where being ignorant is okay, and it's how we move forward by accepting that and then trying to learn more and just be a little bit less wrong over time. Not about being right about everything. And it's very likely right now that you're wrong about a lot of things. And it's also likely that you're ignorant to a lot of things. Not me, though. And it's also it's also very likely that as a scientific community, we're wrong about some things. Things shift over time. So it's really important not to hold on to these beliefs too firmly. And the good news is that in physiotherapy, a lot of things seem to be helpful, and we don't always need to know exactly why things are improving or helping people. What's important is that we know what can help and having a belief that we can help people and being this reassuring voice for people, and just because you're uncertain about some things doesn't mean we need to be uncertain about whether or not we can help people. And I think that's a very common claim that people make about, I guess, this evidence-based community, that we're trying to debunk everything and poke holes in everything and say that nothing works. And it isn't that nothing works. It's just that things work a little bit differently from what we tend to think. And it's okay to be a little bit uncertain with that. And then when it comes to this whole uncertainty around posture and whether or not it causes pain, I hope the conversation that we had is helpful for people. I really do, because I know for a long time, I just did not know what to make about certain postures, because I again, in school, I learned that sometimes it's okay, sometimes it isn't, and structure isn't always an issue, but where do we go from there? And something that really helped me, I already mentioned his name once, but I took Greg Lehman's course, and everything became very clear for me after that. And it wasn't about finding all of the answers. It was just about having principles and a framework for learning how to sort of navigate the world of physiotherapy. So I guess to summarize that thought, gravitate to principles and frameworks more than facts and algorithms.
And I think there's a anxiety that can be created with students or new grads of trying to sound like we know everything when trying to answer a question that a patient has. And I've mentioned this in previous episodes, but it was so relieving watching mentors of mine like say they don't know when a patient asks them something, or provide some potential options. That, I think, hearing that and knowing that there doesn't always have to be a X is causing Y, or this is you're in pain because of XYZ. There's very rarely times when someone's in persistent chronic pain that we can have one exact uh, reason. There's so many factors, and there's just some things we can't answer, we don't know as students and clinicians. And I think it becomes more and more comforting knowing that you don't have to answer with a reason or have an answer. And a lot of times patients like really respect that, and they're not going to get frustrated. And maybe sometimes they're frustrated not in you, but in the sense that like everyone wants an answer, and it may also provide some reassurance to them knowing that there's a lot of moving pieces and variables and things that I can potentially adjust in my life or in my day-to-day that may be able to help. But maybe there's not this one thing that I need to be doing or need to change.
Yeah. I think that last point is like a very, very good one. And I think that uncertainty can often be present in something like non-specific low back pain, where from a diagnostic standpoint, it's really hard to make a firm conclusion about what the source of pain is in somebody. But that doesn't mean that we can't then offer up some suggestions about how to help. So I think in clinic, if a patient just said, if they asked me a question and I said, I don't know, and I just left it there, I think sometimes that's, at least in my experience, where I might lose someone. Um, so I think if they say, what's the source of my pain? I could say, like, I'm not exactly sure, but I have some ideas. Here's some structures that are in that area. And it's really hard to be completely conclusive about these things because there's so much going on there. But with that said, the good news is that we don't need to know exactly what it is in order to help you. And here are some potential ways that we can do that. So I think there's also a good way to say, that we're not sure about some things. Yeah.
Yeah, to that, I had a remote consult yesterday with an individual who was suffering or experiencing tailbone pain during very specific activities like split squats, searcher squats. And we went through this consult, and his sport is Muay Thai. And I tried to dive into, was this a immediate onset? Was this traumatic? When does this occur? Does it occur anytime outside of those specific activities? When it does occur, how long does it last for? And essentially, with all the questioning and all of his history and everything, I ruled out the concerning things. And this happens a lot of times where it's like explaining to the patient, fortunately, I feel very confident, at least at this point, with what you're describing and what we've gone through today, that the things that I would be concerned about that would change our immediate decision making, we've kind of ruled out for XYZ reasons. Moving forward, I can't provide complete confidence as to what exactly created the onset of these symptoms, but here's the things we can do moving forward, like you said. And it was so interesting because we did this remote consult, and he was in his home gym, and I had him attempt some split squats and some zerchers and some rear foot elevated split squats, a variety of positions that prior, a few weeks ago, were upsetting to him. in his tailbone and at the same loads, and there was no provocation of symptoms. And it was this like, okay, I'm trying to test what is the ceiling? Where are we going to find these onset of symptoms? And it never occurred. And at the end, I just said, yeah, I don't know why you didn't get
Mm-hmm.
tailbone pain this time, but my hope is that this provides you some reassurance that this won't be your experience every time. We've ruled out the things that I would be concerned about, that I would refer you to other professionals or to seek other opinions, but let's monitor this and see if we can still slowly ramp up with these activities. And even if you do have some mild symptoms, I'm not necessarily concerned for XYZ reasons. So there was that like, okay, I don't know why your symptoms didn't occur during this appointment. I also didn't know why they initially occurred, but I'm providing context as to, just because I don't know doesn't mean we don't have like steps and action plans moving forward.
Right. Yeah. For an individual like that, like you could say, hey, like over time, like let's try and monitor for patterns, and we can talk about these patterns together and see, you know, what might be the cause of the pain and what might make it worse. And together we can use those patterns to help inform what we do. That's a perfectly okay thing to say, instead of saying, you know, I know exactly what's going on here and here's the exact plan that needs to happen. And I think being okay with this uncertainty and vocalizing it in a way that you described, it also allows for a little bit more creativity and fluidity in the treatment plan, which I like, you know, because again, it's not a blueprint and we may need to change things. So if you're so hard-nosed about the exact way that things need to be, and that you think you have all the answers, it might be harder to pivot if you notice that things aren't going well. So, you know, it's in a way, once you come to terms with how uncomfortable uncertainty can be, it can be so freeing. It really can.
Any other final thoughts or topics you want to dive into before we start wrapping it up, Noah?
Um, I guess just if we had to summarize the whole conversation in one way, it would be, if posture is a painful problem, it doesn't necessarily mean that it's a bad thing, and it's okay to change it in the short term. And ideally, if the person that you're working with is okay with it, I think it's great if we could build people back up so that they could be more resilient and tolerate different positions. And if they don't want to do that, that's also okay, because that's the person's decision, as long as they're properly informed of the decision that they're making. So that, I think if I had to just have a couple sentences to summarize our conversation, you know, that would be it.
Perfect. Well, we'll call it there. I appreciate what you're doing, leading the charge as a fellow new grad with all the information you put out in your own podcast. If people want to find out or hear more about you, where can they go?
As of now, the best places to find me would be Instagram. So noahmandel.physio. The link to my podcast is there. The podcast is called Forward Physio, and it's on all the different podcast platforms. And then, you know, over the upcoming months and years, I hope to be a little bit more involved in education, and maybe we'll be able to find a little bit more of my stuff on YouTube or maybe in courses. But for now, the best place to follow me, to message me, would be through Instagram.
Awesome. All right. Thanks again, Noah. We'll call it there.
Thanks, Chris.